I'm trying to come on Clubhouse.
I didn't do Clubhouse.
I'm trying to come on Clubhouse, but it's not loading
at all. I didn't even turn it on. I just did StreamYard. just did
Oh,
this.
okay, because it came up. I'm like, oh, okay.
Well, it's
Okay.
about, I guess because it's an automatic.
Okay.
It's an automatic thing, but I didn't come up. I didn't even connect. I didn't do any of the things this morning.
All right. Good morning.
Good morning. How are you? How are
Celebrate
you?
yourself.
I'm doing good. I'm tired. It's been a week. I have my to-do list. People just keep adding to my to-do list. I'm like, I don't have time. I gotta go. I gotta get ready. I gotta go. But they still
I
want
know
to add
that's
to my.
right.
I'm about to just shut down and shut down. I
Do what you got to do.
gotta do what I gotta do. Jesus. All right, all right. Let's get. How was your week? How's your week been?
I took off Thursday and because I needed it. I don't. It's just a lot going on.
It's a lot. A lot. And I know COVID is back out in these streets. I'm hearing like
Mhm.
every day somebody is uh contracting COVID, and I'm like, ooh, I feel like I'm dodging bullets. I feel like it's Russian roulette. I was like, let me get all these masks back out, get everything back together. If I need to wrap my whole head up when I go out. So yeah. I mean, I haven't heard anybody be very, very sick with it,
Right.
but just, hey, I got COVID. I got, it's like, oh my goodness. Okay.
It's the same here because even in the reviews that because I've started seeing it. I started seeing it in July actually when
Mm,
people were starting to be admitted with COVID, but fortunately, like it's not anywhere near to the level of acuity like it was before. Like nobody's in acute respiratory failure, nobody's on a
right.
ventilator, so that's good.
Right. And I prayerfully, it's just for those folks, it just does what there's no long-term effects or nothing that comes with this new strain. I mean, I guess they're still um learning about it and investigating it. So hopefully nothing comes. I did read somewhere it was talking about like rashes or something. That was a new symptom that people may see. But so then I'm looking at my skin every day. I'm like, Lord. And then the bees, oh my God, the bees are out and just buzzing and trying to sting everybody. It's a whole hot mess out here in these streets, but here we are.
Oh Lord, fall is upon us.
Fall is upon us, and fall is my favorite time of year. Y'all making it hard.
All
Y'all
right,
making it
it all be
hard.
so simple.
Right. Exactly. All right. Let's get this party started. So, welcome everybody to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, the physician burden, the nurse practitioner's plight, the revenue cycle at large, just all of the things. And
Mhm.
as you come in, don't forget to hit the thumbs up or like button. I am Clarice Warner. I am the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. One of our sincere goals is to make sure if you're interested in becoming a certified marketable medical coder, that we provide you the tools and information that you need to accomplish that task. But first, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Well, before I introduce my co-host, let me share with you information on a free, yes, free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. I feel like I need to dig out that hat again. Let me put that on here one day. All right, all right. So if you are interested in information about the free email course on the 5 steps to become a certified marketable medical coder, then check out the link in the description box. So joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been an LPN for 3 decades. I transitioned into HIM in 2014. And during the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other healthcare practitioners with clinical experience. I help them transition into the wonderful world of HIM.
And oh, what a wonderful world it is. How's everything been going?
It's going well. I have a, I have a new class, and it's just like in the very beginning, it's just trying to get that switch to go off because you have to change the way you think.
You do. My class, it's like they're learning about ICD PCS, and not everybody, the majority of them are getting stuck on those root operations, particularly removal and excision, and understanding like the differences between the two. And it's like all my comments, don't forget to read the definitions of the root operation. Don't forget to read the definition of the root operation. Like it all could be so simple.
PCS is all of, if you don't get to root operations, you will
your whole code is trash. It's all gone. And I'm like, I'm looking like, nope. Like if them first 3, it's a wrap for you. It's a wrap for you. So yeah, so it's interesting. Again, just and that's something that you just really have to know.
Period.
That's something you really have to know. Or know to go look it up. there's you don't have to memorize, but know to go look it up.
I say the same thing. You just got to know where to go to find it, because what I do is like, because I still have access to the HEMA encoder, so I'll pull it up and I tell them, because what I tell everybody, even in my CM classes, I said, whether you believe it or not, a dollar amount is attached to every one of these codes. And when they put in the wrong code, I'll show them in the encoder how it affects payment.
And that right there is the game changer right there. For some reason, I don't know, seeing the dollars, folks, it changes folks' mind. Just looking at some dollars. I don't know. All right. Well, let's see. Before we get started, let me remind you that we are having a conversation. And so we want you to join in and add to that conversation. So by doing so, if you're joining us via Facebook, YouTube, and LinkedIn, you can just use the chat. Place all of your comments there. Don't be shy. Your opinion matters and is welcomed here. Always. Also, if you have a question, please type Q first so that we know it's an actual question for us and we don't miss it. So for those who are joining us today, either live or watching the replay, today we are talking about recent developments of AI, or artificial intelligence, and health information, specifically coding. But first, let me give you a little something. Martin Luther. I got some information about our documentary too from the church. I should have put him on camera. Should have started it right then and there. Like, you're gonna be the first victim of the documentary. All right.
We almost got to get ready for first Sunday.
Yes. And communion and all of the things.
Yeah.
I might have a little communion cup in here somewhere. Don't play. All right. So I really don't have much by the way of church announcements, except that we will not be here next week. I keep trying to get Mr. Jesse to take over and do it, but because he won't, we won't be here next week. I will be traveling. I will be taking a much needed little vacay.
Good.
So yeah, we won't be here. But if you have information or if you have things that I should know about, or we should all know about, don't forget to let me know. You can email me, send me the information, and we'll or put it in the chat, put it in the comments, and I can pull that information up. Or you can put it in Mr. Jesse's comments as well to let us know, and that would be something that we can take a look at, and this will be something that we can spill some tea about. So yeah, Mr. Jesse, do you have any announcements for the people?
No, I don't. I'm just glad you're getting some time away.
I know. If only I could leave my computer at home. I don't think I've ever not traveled with my computer. Now that I think of it, I don't think I've ever. At least in the last 10 years, I don't think I've ever traveled without a laptop. Ever. I have not. That may be bad, but it is what it is. Good morning, Crafty Coder. Welcome back, ma'am. Welcome back. Oh, let me get rid of this banner. Okay, so that is my church announcement for the day. Let's get into this stuff we got going on. So, first, before I get into the AI thing and the HIM and coding thing, our friends over at the American Medical Association, I promise you, they be in my inbox. I don't know. Maybe I got a direct line. They be in my inbox. I promise. They come. Maybe they coming for me. Should I feel some kind of way? Should I be watching my back? No, but this one is actually sort of good. As you all know, the American Medical Association is responsible for the CPT manual. They are the sole proprietors of CPT, so they have some skin in the game. And I guess for purposes of a church announcement, I guess if you will, don't forget, if you are interested in getting in-depth preview of the CPT changes, the 2024 annual symposium is virtual again this year, which I love because it sometimes can be real cold in Chicago, but it's virtual November 15th through the 17th. It's actually a good time, actually, if you get an opportunity. It's a little pricey. If you purchase your it's a substantial discount if you get on the early bird, and the early bird payment is due, or the last day to get the early bird is the 30th, I believe, September 30th. Like it goes up almost $250 after that. So if you can or will, or if someone, you got a sponsor out there in the world, join us at I think I'm going this year, so I need to go ahead and take care of that before I travel. But anyway, they put together an article. Kevin B. O'Reilly from he's a news editor, put together an article on the 8 medical coding mistakes that could cost you. And of course, they're speaking to other, I can't even say provider, physicians.
Yeah.
They would really come after me then, wouldn't they?
Yeah.
And so they have been talking about government and private insurers audits have revealed unfortunate cases of fraudulent or abusive medical billing practices. And they kind of break down a little bit of the terms fraud and abuse. And fraud is where there's an intentional misrepresentation. So somebody is actively on purpose doing something that they ain't got no business doing. And then abuse is the falsification was an innocent mistake. But unfortunately, mistake or not, uh, typically the government feels that you should have known. You are ultimately responsible, and you should have known about what's happening. She's like, okay, don't say provider. What's happening with your coding and billing? So, and then they say for example, abuse could involve coding for a more complex service than was performed due to a misunderstanding of the coding system. Either way, again, they feel like you should have known, and before that bill goes out the door. So here are the things that they are mentioning, the 8 items that they suggest that you kind of can help your provider, physicians or providers, because actually they wrote this to physicians, but this applies to providers as well. So physicians and or providers. How about that? First is unbundling codes. So when there is a single code available that captures payment for the component parts of a procedure, that is what should be used, period. You should not, just because you think you did a whole bunch of stuff, and you probably did, but if one code encompasses all of the things that you did within that particular procedure, that is what is to be coded. You don't capture or you don't code all the individual things. That's unbundling. And It says unbundling refers to using multiple CPT codes for the individual parts of the procedure, either due to misunderstanding. They use this a lot in this article. That's why I'm chuckling. Or in an effort to increase payment. Either way, it's wrong. So don't unbundle. Upcoding. We've all heard about upcoding. They give an example. You are a physician in a specialty such as oncology that often has highly complex patients. Due to this, you always report the highest level evaluation and management service, regardless of the actual condition your patient presents with. While this isn't always upcoding, you should accurately report the level of E&M code based on the patient's condition and not just based on your specialty. Sounds like upcoding to me if you saying that you did something that you did not do based on your patient's condition, and the documentation does not support it.
Exactly.
And then they go on to talk about examples of outright fraud in terms of upcoding, where they give an example of a psychiatrist who was fined $400,000 and permanently excluded from taking part in Medicare and Medicaid due to upcoding. He billed for 30 or 60-minute face-to-face sessions with patients when in reality, he was only meeting with patients for 15 minutes, each to do meditation checks. Not a good look. The next is failing to check the National Correct Coding Initiative edits when reporting multiple codes. So CMS developed the NCCI, which is the National Correct Coding Initiative, to help ensure correct coding methods were followed and avoid inappropriate payments for Part B Medicare claims. These are automated prepayment edits that are reached by analyzing every pair of codes billed for the same patient on the same date of service by the same provider to see if an edit exists in the NCCI. If there is an NCCI edit, one of the codes is denied. NCCI edits will also typically provide a list of CPT modifiers available that may be used to override the denial. In certain cases, clear direction is stated that no modifier may be used to override the denial. An example they provide here is you bill for a lesion excision and skin repair on a single service day. Coding guidelines say simple repairs are included in the excision code. So separately coding the repair would be wrong and generate an NCCI edit. But if the repair was performed on a different site from where the lesion was removed, it is appropriate to bill for both and append a modifier to let the payer know the procedure was indeed separate from the excision. The next thing is, and Mr. Jesse can jump in at any time, failing to append the appropriate modifiers or appending inappropriate modifiers. This one pretty much talks about reporting modifier 50 bilateral procedure to a procedure code that already includes a bilateral service. Another one is overusing modifier 22, which is increased procedural service. You must include proper documentation to explain why the procedure requires more work than usual. For example, a physician excises a lesion located in the crease of the neck of a very obese patient. I swear this is one of my questions I use for my class. City makes the excision more difficult. In such a case, appending a modifier 22 to the code used to report the removal can indicate the increased complexity of the service. Another one is improper reporting of the infusion and hydration codes, which are time-based. Again, good documentation of the start and stop times are essential for medical coders to properly bill for these services. And then there are wrinkles involving services that are provided over 2 days of service. For example, a continuous intravenous hydration is given from 11 p.m. to 2 a.m. In that case, instead of continuous infusion, the two administrations should be reported separately as initial with code 96374 and sequential with code 96376. Next is improper reporting of injection code. So you only report one code for the entire session during which the injections take place instead of multiple units of a code. And finally, reporting unlisted codes without documentation. If you must use an unlisted code, and there are plenty of them out there, to properly bill for it, you must properly document it. And oftentimes they will ask for that documentation as well. So those are the 8 things that the AMA wants you to know, providers and coding folks at large, of the 8 coding mistakes that could cost you money. Mr. Jesse, you want to have anything to say about those?
I feel like these are the same 8 they've been talking about since the entire time.
I cannot with you. Well, maybe this is all they got in their pocket. I don't know.
I'm telling you, it's the same stuff over and over. How long have they been talking about upcoding and unbundling? I mean, forever.
Forever and ever and ever.
I mean, and these modifiers. I mean, but the thing is, if you like, what? Because for me, what I was like, I just can't, because when they came out with the changes with modifier 59 with all these X's like XE, and I'm like, what? They don't even know how to use 59 correctly.
Correct. And 25, because there's a whole I think I'm doing a video on that. There's a whole guide that they've released on their intent, I think, for modifier 25. I think part of the problem or part of the issues that comes up with this is you have your guidance from your coding manual and guidelines, but then you got provider guidance that may differ. So not only Medicare, Medicaid guidance that may say something different than what the actual definition is in the code book, but then you also have your other third-party payers that may also skew how they want modifiers applied to certain codes. So that can be a little part of the confusion, or as they said in that article, misunderstandings related to that.
Now, the only thing that I will say is, and I think that especially when it comes to Medicare and Medicaid, I think that there needs to be standards across the board, because we all know that they have, NCDs, but I don't think that there should be much variance between LCDs. I don't see the need. I think that everything needs to come from CMS and everybody uses it.
Yeah, these federalist models, boy, they just be killing me. Like, the thing is, if you you at the top say this is how it's going to go, then everybody else needs to follow suit versus, you know, you want to get everybody else's buy-in. So you have all these different carriers and all of these different MACs that say, well, no, we've interpreted it to mean this, that, and third. And if you are in a place, say you're like, we have a tri-state area. We have Kentucky, Ohio, Indiana, and a lot of other places have that same thing where you're kind of on the cusp or on the border. Well, then you need to be responsible and know what the definitions are, or what the intentions are for the different MACs that are a part of the area in which you could potentially be coding. And yeah, it could be a lot.
Because
so I agree. They should just have one. I totally agree. Crafty Coder is also in agreement. Our person in the streets. There should just be one set of guidelines that will clear some of this nonsense that we have out here.
Because I read an article a couple of years ago where this provider, physician, has said that he documented a condition that was paid in one MAC with no problem, but he documented the exact same way, and the patient had another MAC and it was denied. So you shouldn't. That should not be.
That shouldn't be.
Now that is a burden.
That is a burden. I will say that.
Right.
Having to jump through the hoops and understand and know what the requirements are for these different MACs is a mess. Okay. So let's get into this artificial intelligence stuff and coding. Well, first let me start with there was a webinar yesterday that I sat in on from the South Asian Bar Association. Don't ask me how I got associated with the South Asian Bar Association, but I was.
We have questions, okay?
Y'all know I love all the people, but they are from the and it's specific to Washington D.C. So I think it's tied to George Washington University, and I have gone to a couple of some of the law stuff. So I think that's how they got my name, and I'm tied to that. But anyway, I was like, oh wait, y'all talking about AI and healthcare. So it was titled Artificial Intelligence in Healthcare, and it was actually pretty good. It was an hour, well spent. The one thing that they talked about was generative AI, which is kind of what we know, which generates stuff or generates information, similar to like what GPT is, that we all have heard of over and over and over again ad nauseum, versus predictive AI. And predictive AI, and they also talked about like clinical decision support and how AI actually has been around for a very, very long time in healthcare, just under different auspices and different uses. So and these were attorneys that was hosting this particular webinar, but one of them mentioned how taking. So she talked about med students and new physicians, and having them, it's so much technology or so much new medicine and new therapies and treatments and all of this, and it's just impossible for them to learn and know it all. So AI, this predictive AI, can be helpful for them. And girl, I love it too. I ain't gonna lie, I love it too. But this can be helpful for them in making sure that they stay abreast of the not necessarily the trends, but evidence-based medicine, evidence-based treatment, etc. And so then another attorney was like, and that's all well and good. However, legally, think about the malpractice that could potentially be a part of this in the event that this becomes accepted practice. So in right now, I guess it's more facility or health system based on their policy. So there's no kind of rules or rigs put in place. They're scrambling to get them out and get them together, but there's nothing set in stone. But say you are a patient and you see a provider and something goes left, and there had been some sort of information that was provided through AI that was evidence-based, and that provider chose not to use it. At what point is that not considered malpractice? Because you were provided with information that could potentially assist or help you in treating whatever the person has, and you decided, I don't need that. I already know this is what I've been doing, or whatever. However, your decision was not based on quote unquote evidence based. And of course, that was the key to all of this. It needed to be evidence based information. And so, that she was like, that opens up a whole different can of worms there. Cause is that malpractice or is it not? And again, right now that's sort of open because you don't know, because there is no hard and fast rules or regulations on how it's set up. So, those were some of the things that they talked about. So it was a real interesting looking at the perspectives, particularly from the healthcare attorneys on their thoughts. Most of them, like you had one, she was like, she was not a fan at all. And then you had another one was kind of in the middle, and then you had another one that was like, this is great. But the one thing that that really, I think I wrote it down, you know how I was like, wait, she said what? That really stopped me was particularly with I think the clinical support and just getting the information, clinical decision support and getting information is, and the data, it's not about understanding what happened. We should be away from that and think about, like, how do we prevent it from happening? So our focus with the data that we're getting is not about, okay, well, let's get all this data. Let's look, okay, well, what happened? Well, no, we should be beyond that. It should be more about understanding how to prevent this from happening. And then they also talked about even using the data with AI to, and I think this was the one that was pro AI, but using this data from AI to help different groups of the population. So, you understand that, and I'll use sickle cell for example. So, sickle cell, primarily African American disease. There are certain parameters around different responses to treatment, medications. People vary depending on, where they live in the world, if they have it. And so AI should possibly be able to take all the data at a relatively quick pace to say, okay, well, based on you and people who are similar to you, this, and the third. And so that was another thing that they were talking about, how AI could be good in helping understand even culturally different people and how, and I think we talked about this too, like how medications or different treatments are different for different people. And so being able to get that data and look for the evidence-based medicine that has been out there and supported can help providers, physicians in their decision making. Did you want to jump in?
The only thing now, I'm kind of agreeing with the attorneys, because when you say, when somebody says you were using you didn't use information that was available, like with this, like when, because there's a lot of information out here that is not valid. So who is responsible for, who is the de facto decider of what is guidance and what is just, because just because a whole lot of people do it doesn't make it right.
Correct. Well, again, they stressed the evidence based, and so it's when they mention something as evidence based, it's primarily something that has been researched, and published, and the community that's involved, or the quote unquote experts in that particular area, have all agreed or opined upon. So sometimes you will have evidence based information or whatever for something, and you can have evidence-based information against something. But then it takes the person who has to make the decision to be versed on either side, coupled with the person and this is strictly, I'm just using this example in medicine, coupled with the patient that is presenting before you, and what they're bringing, what symptoms they have, what their history, their medical history is, etc. So you would need to take that into consideration. But yeah, just like looking at WebMD and saying, oh, this, that, and the third.
Right. Because that's my point. Like I understand what evidence-based is, but you don't need ChatGPT to find evidence-based information.
Oh, absolutely not. But
So,
there's, like, I think the thing is that it can come to you quicker or whatever. I don't know. Or in the event that you're prepping, I don't know who all really does this for real in this day and time, but in the event that you're prepping for the visit, you can quickly get some information to be able to assist. I don't know.
okay.
But that's what they threw out there. But anyway, so I wanted to preface that with that. And then this is where I found out that the University of Texas Health Science Center at San Antonio and the University College at the University of Texas at San Antonio are launching the first known program in the United States to combine medicine and artificial intelligence. So the person will get a Doctor of Medicine, or MD, from UT Health San Antonio, and a Master's of Science in Artificial Intelligence from UTSA, for a 5-year MD/MS program, enabling physicians trained in San Antonio to uniquely lead in the practical use of artificial intelligence to improve diagnostic and treatment outcomes. So they are the first to offer this particular partnership of a dual degree for physicians. What you think about that?
I think that is great for research if you're that kind of physician, because we all know, just like in any practice, not all physicians practice. They segment. So I think it is great, but I think for the average run-of-the-mill physician, I don't see where this is going to be beneficial, because I think that what they should be doing is they need to be teaching them nutrition and how to document.
My first thing, I was in my feelings. Let me just say this. I was when I first heard about it, and then I read the information, I was totally in my feelings. Like, why wouldn't you have a dual degree with like HIM? Why wouldn't you have a dual degree to understand, the business side of healthcare? What? And maybe there is. Maybe I jumped the gun, but just hearing this, I was like, I often hear physicians and providers tell me, we have no idea how that your world. We have no understanding. We hear just only time we hear about something is when the folks is knocking on our door talking about we need to see some documentation for some charts or a review or an audit or whatever. It's like, I have no idea. We were taught how to document, but you never understood where that documentation lands and the importance of that documentation and all the different factors that documentation impacts. So I was in my feelings like, well, even if it ain't a whole master's program, something, I would think at least a class, can you slide at least a class in or something, or a mandated something.
Well, the reason why is because that's not sexy. AI is sexy. They, oh,
Keeping your dollars and your coins in your bag should be sexy too. I'm just saying. I don't know.
but yeah, well, we know that's not on their radar because that's why the government collects billions of dollars in overpayments every year.
True.
They have washed their hands of HIM. That is beneath them. That's for us, mere mortals to
Figure
handle.
out.
Right. While they talk about their compassionate sacrifice and AI.
Yeah. She said, now they need 3 full months of just coding. Exactly. And documentation. Don't forget the documentation. Again, as we have always stated, it can all be so simple with just appropriate complete and accurate documentation can make this whole world a better place. The
Because
whole world of HIM.
because we all know that
Healthcare in general, a better place.
we all know that AI is here to stay. Nobody is. You'd be crazy to think that. But if you want to be effective, and I'm not saying that AI doesn't have its place in healthcare because it sure does, but that shouldn't be because I can definitely see this becoming a thing. And I in terms of like the everyday, person that's sitting in their office where their provider or physician has overbooked, that's not going to really help them.
No. And then I can also see another side. So they have type A competitive personalities usually. So imagine this overarching feeling that you have to be in the know. You have to be on the cusp of understanding what's coming down. You have to, that coupled with the production of medicine now, that would drive me crazy as a physician or provider, period. You're right, Vicki. And hey, Vicki, like Jesse said, it sounds good, but doctors need to first learn to be good doctors and real thinkers. You are absolutely correct. She said, the crafty coder says, if they learn how to code right, they will know what needs to be documented to code it. Hopefully. Hopefully.
But the thing, and even to piggyback off of the crafty coder's point, you can still, because I don't think they on a very basic level, I don't even think that they, when I say they, I mean providers, physicians, whatever you want to call them, you would think that they would learn from the queries that people send how they should document. But can I tell you, I've been sending the same queries and they never change. It's like, when is it going to occur to you? Like, why would you? I just don't get it. And it's just like they're just totally divorced. Like they do their thing, and it's like, okay, well, if they have a question, I guess they'll ask me. And they never change. It never gets better, which is crazy to me.
I agree. And to your point, the conversation has come up about query fatigue. Well, you wouldn't have the fatigue because I wouldn't keep asking you if you made the adjustments and corrected the problem. Period. It could all be so simple.
I mean, I don't understand. It's very basic. First of all, I don't understand how you can, because there should be a policy, just like there's a policy that an H&P has to be completed within 30 days or 24 hours after inpatient admission. There should be a time frame for the discharge summary to be completed as well. You should not. How is somebody in a hospital for 5 days, 10 days, and you do not have a well-written discharge summary? You have the discharge summary is supposed to tie everything up. There should be no question.
No questions. No question. And I think somebody thought that would be the case with this whole, it should be coded within, immediately or 2 days after the discharge. I think somebody thought the same thing. Like, once they wrap all of this up, it should be ready to go, move on. Not realizing folks is dragging their feet on on wrapping this all up and summing it all up and getting the information, and it's a whole mess. It's a whole hot mess.
I have a conversation after the meeting.
Okay. So somebody says, how can you recall something that many days later? I was having the same conversation with somebody recently about some documentation. And I'm like, it's like, well, they're busy and they're doing this, that, and the third. Now, this is not a physician, it's a different type of provider. But they're busy and they're doing this, that, and the third. And how in the world can they possibly take the time to document? I said, how can they possibly not? You want to bill for this service, but then you're gonna just at a bare minimum get a napkin and write down the hot points or whatever. You may not be able to go to your computer right then and there and enter the information for the documentation, but you got to have some kind of recall. And if you're that busy, you're doing multiple tasks and multiple things with multiple people, there is no way that you can accurately remember all of that you need to have documented. There is no way. You have to be able to jot this stuff down. Folks need to be walking around with little pens and paper everywhere they go.
Well, what I can say, like where I work, we have to construct our queries so all the information they need to make a decision is in the query. They shouldn't have to look up any. We have to put in lab values, documentation, reports, even that, like not full reports, but like the summary, like the impression. So you have to put all this into a query and send it to them. So all they have to do is just look at what you are asking and look at what you have included and then make a decision from that, so they don't have to go to the chart. And what happens sometimes is like you run out of space, like you have too much information. So you have to sometimes I have to scale it back because you'll get a message, it's too many characters for it to send. So then you have to scale it down. And then when you scale it down, that's where it gets a little murky, because if you're trying to say that this person needs this information to make a decision, sometimes you have to include a lot of moving pieces for them to get the whole picture. So that's what happens. You're supposed to put all this information in so they don't have to. They can look at it and make a decision based off of what you submit.
Let's see. Lee Love says, as a well-rounded RN, the doctors are so busy that they don't have time to code unless the code is attached to the diagnosis. The best way is to chart at the bedside. And then the Crafty Coder says, I'm definitely side-eyeing them. We got an old doctor right now that is still working on documentation from July. Really. Ooh,
but I just wanted to comment on Lee Love's post. Like, it's not physicians' jobs to code.
It's not.
I don't even know how that ever
got started. No, wait. It depends on your institution. It depends on your organization, because some of them are pushing them to code. They feel like it should be their job because ultimately they're responsible. Now, that's a whole other conversation.
Yeah. I'm going to maintain that only people who are certified coders should be coding. I don't care what you could be a brain surgeon. You have no business trying to enter in an ICD-10-CM or PCS code, period.
Absolutely. Absolutely. Well, and go ahead.
But it is your job to document appropriately so I or somebody else can code appropriately. That is their job.
That is true. And that's a beautiful segue into how artificial intelligence is leveling the playing field for E&M coding. So, this article was by Chuck Buck from ICD-10 Monitor, and it says it's certainly not breaking news that artificial intelligence is making inroads in healthcare. We've all heard about all kinds of stuff AI doing all kinds of work in all kinds of fields, specifically in healthcare, that are accomplished by humans, nurses, administrators, lab techs, and coders. But just how effective is AI when it comes to selecting evaluation and management codes? So there was a recent assessment conducted by Mazars USA LLP, which is an independent auditing firm. And they validated that the AI coding engine in the Calm Waters system recently achieved a 97% accuracy rate. And that was 2 points better than the industry benchmark. The benchmark is 95% for human coders. This is a powerful validation for our company and our technology solution, says Calm Waters AI president, Joe Farrell. And he said this in a recent press release. He said, "We are thrilled that a globally respected third party like Mazars has assessed that Calm Waters AI is as accurate as we have always believed and delivers the bottom line results for provider groups that we have promised." He goes on to say that more than 1,000 providers Calm Waters serves and have audited, the company has found an average of a 63 to 65% accuracy rate across organizations of different sizes and different specialties. But in seconds, Calm Waters AI delivers the bottom line results for providers that we've promised. As a result, practice groups are optimizing chart accuracy and reducing audit risk while gaining up to an hour per provider each day that would otherwise have been spent on documentation. Such high rates of accuracy could lend assurance in the potential for AI coding, particularly as it pertains to mitigating audit risks. For coders, it should generate a greater sense of confidence in the quality of the output, according to Angela Jordan, who is the executive vice president of ChartPal, the E&M documentation service of Calm Waters AI Incorporated. Jordan also noted that coders' responsibilities are likely to evolve when using the technology. Instead of spending their time pulling out components of the medical decision making, they will simply validate the E&M level and then focus on other coding activities, Jordan said in a statement to ICD-10 Monitor. "I am thrilled that our AI is setting new standards in E&M accuracy. The results from this review underscores our commitment to being seriously precise. Calm Waters AI is not just advancing technology, we are making a significant positive impact on the business of healthcare." Your thoughts? I can
This
see your
sounds
face.
like more compassionate sacrifice foolishness.
So
That
all
is
I
just
thought and all I heard was this will be one way that you push providers, doctors into coding.
because see, this is what I have become keenly aware as I get older that you have to read between the lines a whole lot.
Sir.
And what I
Sir.
want, because it's
That's what I
awfully,
heard. In
because it's
between the
awfully
lines.
funny that they only mentioned E&M.
Uh-huh.
And why would that be?
Do you know how much money E&M generates every year?
And that is where all of the kerfuffle comes around
Yes.
in terms of auditing. And
Yes.
I'm like, okay, so when they touted this 97%, who checked A&I? I mean AI, who audited that to make sure that it was valid? Like you just because you can skew numbers any way you want when you want to, like numbers don't lie, but they can be manipulated.
Mm. Or
And
used to further your position. So I
right.
would be interested in seeing that Mazars report. What exactly does that report say? And what did they actually what was the parameters? What did they look at? What did they do? What was the process? That I would want to see before I can be like, well, this is the greatest thing since sliced bread.
Yeah, because
Is it?
I'm
Is
not
it?
buying it. I'm not buying it because E&M covers a huge spectrum.
She
Huge.
said it's the vocabulary for me, kerfuffle. Ah. You know we get it, give it all.
I just I'm just side eyeing it because I'm just I'm just gonna sit right here and we're gonna sit here on Saturdays and watch this unfold because it's going to be
No,
interesting. That's all I
that'll
can
be
say.
interesting.
But I also want to say I'm actually kind of glad because this is where I always talk about how AAPC and AHEMA are missing the opportunities because they should be the people out in front of this. And they should be the ones preparing their members for the future, because what's going to end up happening, and I'm not going to lie, I'm here for it, and I'm going to be sitting right here talking about it, because what is happening is the powers that be in HIM, these gatekeepers are gatekeeping themselves into extinction.
Yes,
That's
they
what
are.
they're doing. And because they're so busy trying to hold on, instead of bringing people in and making coding strong, making it so, guess what? AI can't beat these people because they're so good. That's how good they are. And they're so busy trying to gatekeep and trying to make themselves look good that all they have done is they have allowed outsourcing.
Yep.
Yes, they have allowed outsourcing because of gatekeeping. There is no reason for any coding position to be outsourced. There are enough coders right here in these here United States who are qualified for jobs, who want jobs, but can't get them because of gatekeeping, which has led to outsourcing. Now, between outsourcing and AI, a whole lot of people are going to lose their jobs, and I'm here for it.
And trying to see what it looks like. I'm the math is not mathing. Let's start there. I was just out on an AAPC site, or I'm sorry, a Facebook site group. The American some for coders. I can't think of it off the top of my head. I think I've talked about it. I mentioned it before. And all I saw was post after post after post after post about people, organizations looking for all kinds of coders, from uh, professional coders through specific surgery types of coders to ED to it all of the things. I mean, literally post after post after post after post, to the point I'm like, is this all y'all posted here? Like, there's no other information. No, that was all it was. And then you go deeper, and somebody is telling you with details. Send your resume here. Send your resume to this person. Do this for that. This that, and they're all over the gamut. Part-time, full-time, remote, in-house, whatever it is that you need. All of these jobs. Then you have all of these people who are looking for these jobs. The gatekeeping is real.
Very.
The math ain't mathing. The math is not mathing to me.
Very.
I don't understand. I don't
Because
get it.
and I don't. The thing that I don't. Well, I do understand. I understand it completely,
Well, tell us about
and
it.
because this is what, and get at me in these comments, because I'm getting ready to go there.
Let me get. I need some more hot tea, but I got enough in here for that.
This
Go ahead.
this is a woman problem.
A woman problem?
Very much so. I'm getting ready to tell you.
Tell us about it.
I have been in female-dominated professions, nursing, now HIM.
Mm-hmm.
They are run the exact same way, and they all have these problems. Oh, we don't have enough help. We don't have enough staff. But they gatekeep themselves into a corner. They don't want everybody in. They're not for everybody, but we still have a need. And I'm going to even go a step further and say it, because I didn't have my Red Bull and I'm feeling frisky right about now.
Wait a minute. Red Bull gives you ring.
It is white women that has gate kept nursing and HIM, and they have done it to the point of almost extinction. Because how is it that somebody that in male dominated professions, like let's just take computer coding, how is it that you can go to a boot camp? You could be a truck driver, go to a coding boot camp for 4 months and come out making $80,000, but you go through an entire coding program, get certified, and it takes you a year and a half to get a job.
That makes no sense at all.
I'm gonna tell you, gatekeeping. That's why.
Yeah, because the math ain't mathing.
It's ridiculous.
I'm finna use my CPCI to train coders, and we gonna go after these government contracts for the payers. All right,
That's the
now.
move, Crafty Coder. You better say that. That's the
That's the
move.
move. That is the move.
And
That
come
is the
after all
move.
the gatekeepers.
Yes. You know, we are you know, we resilient. We move, we go, ain't no mountain high enough. We go around it, we go under it, we go at it, we go through it, we go however we got to get to it. Ah, you're absolutely right. I mean, history has proven, history has shown itself over and over again, um, that seems to be the case. There's no refuting that. And as I said, these numbers are not, the numbers don't add up. I don't understand. I mean, I promise you, this group had so many positions. That's all I saw. At least 20 posts right after another talking about the different jobs, and not just one job per post, multiple jobs in these posts that people were looking for all over.
And I've had a 30-year front row seat to the shenanigans. I've seen it. All of my working career, I've seen it. And since I've been in HIM, this almost past 10 years, I've seen it. But yet and still, they always say that they need help. But you don't need help because you don't want help.
You don't want help. You don't want help because there's help out there to help you. There are people out there to assist and help, but you don't want.
Because they're like, it blows my mind, but it's all a result of gatekeeping. Like, there's this person I follow on LinkedIn. When I tell you, not a day goes by where they're not advertising for CDI. I mean, they even have travel.
It's for CDIs over here in that group I mentioned as well. There's CDI positions too.
But as soon as you get to it, the first line, RN only. Okay. And that is a construct of gatekeeping.
Mm-hmm.
Because I understand now how they do it, and I understand why they do it, because I see it. They bring people in with no experience, and this is why when you get into like the CCDS, why they require you to have 2 years of experience, because it takes you about 2 years to learn how to do your job. But because you have that initial RN, you basically can fail forward until you get it right. And because ultimately CDI does not submit a bill, coders submit the codes for the bill. So when you have a discrepancy between you and the coder, you're supposed to work it out. So the coder will correct the CDI until you get to the point where you learn it, and then you know how to do it, then it's right. So that takes time. But imagine if you took somebody who was a coder, because in CDI, you have to learn something. You either have to learn the clinical piece or you have to learn the coding piece. Nobody is born ready to go walk into CDI. That's a misnomer. If anybody's telling you that, that's a flat out horse cocky. But
there's some more vocabulary there for you, Crafty Coder.
But rather than only you're basically put in this position, this gate at this certain level, because the overwhelming majority of RNs in this country are white women. I'm done. I'm landing my plane and I'm writing my book.
And I'm here for it all. For it all. But that is a very interesting perspective as it relates to that, because again, I don't understand. And not even and let me just say this, even with the jobs and the information and the people who were replying back and forth, these are seasoned coders or seasoned CDI folks or seasoned, these weren't necessarily brand new. You had a few that was sprinkling in, and then even in some of the posts, they would indicate, new coders welcome this and that, or you need at least 2 years or whatever. But they would put that information in the post. But the people who were looking or replying saying, oh, who do I send my stuff to? This and and they would kind of give a little quick elevator pitch of who they are and what they bring to the table. And a lot of them were seasoned folks. I've been out here, this and that, third. I'm just looking for this or I'm looking for that. I'm like, so either to your point, that perspective of the gatekeeping and people are keeping people out and they won't help, but they really don't, or folks ain't trying to come up off that bag. That could be another thing.
Well, like, that's a whole other thing. That's a whole separate, because even once you even get in, because me personally, I've applied for jobs and I'm like, no, I'm not. No, you're not trying to pay me that. Oh, well, that's all. That's the max we can offer. Okay, thank you very much. No, they want you to have all this experience, but they're not even trying to. No, see, because with experience comes money. Like if you're trying to pay me hourly, like you got to start in the high 4s, and then come over to a 5. Like, no, screw that. No. And they have the money. It's not that they don't have the money. They have the money. They just are not trying to pay you.
They just don't want to pay you. You're absolutely right. They want nickel and dime, y'all.
Yep, for real.
So that could again be another piece to this complex puzzle of HIM. The business of HIM. There's more on this on this other side of this business.
And this is why, see, businesses don't have a problem paying coders. When I mean like computer coders, they don't have a problem paying them because they know the value that they bring to their company. They know that they can maximize revenue. So why does that same logic not apply to HIM, where you are directly impacting revenue?
Directly. Either getting it or holding on to it.
And the difference is who is running the show on both sides. And if you see the difference between who's running the show, you'll see why the shows get ran the way they get run.
Ooh. Ooh. And on that note, we are at the top of the hour. Woo. Yes. So look at how, some of so we want to talk about AI, but I guess even, I want to say before you even have that conversation, but the conversation is already out there. So while you are having that conversation, there are other pieces and nuances to the conversation that needs to be had. Other topics, and it may be uncomfortable. It may be one of those unpleasant things where you gotta come on in and sit down and sit in it for a minute. But these are some of the things that need to be discussed as it pertains to this. And ultimately, we all know who at the end of the day is impacted by all of this foolishness: the patient, the consumer. Ultimately, they're the ones that are impacted at the end of the day. And why not do what's best? Either both from a healthcare treatment, clinical perspective, as well as a business perspective, financially. Why not? Well, this was good to you. Go ahead.
Exactly. And the last thing I want to say is, like, the business model in HIM has changed too. It has become like a business, because before, it just like nursing used to be. Before, people were brought in, because this is like when you become a nurse, like, you get a license, but you come in, you don't know anything.
It's a training ground. This was to help you train and get people the additional knowledge, the on the job training related to, yes, you come in with your book knowledge and your education, but now you need to be able to apply it. And so there was room for the additional teaching and training and considering, how to groom people into different positions. That's gone. That's gone.
But it started.
It's about me and getting mine.
Exactly. So now it's like, so there's no room now that you come in and they expect you to be able to perform. That's not realistic. Everybody has an onboarding process. Everybody. And
so and nowadays it's dual fold. So not only are you onboarding to an organization, you're also onboarding to that position and the task and roles within it. Especially if you're brand new and you've never had the experience, but they want to cut that latter part out, just onboard you to the organization and send you out there to the wolves without, and then tell you, oh my God, you're not meeting the standard. You're not doing whatever.
But the reason why,
help people give them the tools that they need to do the jobs they need to do.
But the reason why that stopped is because now the people in these key positions don't know how to do what coders do. Like they couldn't frontline code if their life depended on it. So how can you?
Yeah, there's a disconnect. There's a huge disconnect there.
Oh, it's massive, and nobody's talking about it.
But us.
Truly, everybody else is out here on some foolishness and trying to make it like it's all roses and chocolate, and it's not.
I was waiting for the unicorns, and rainbows. You done flipped the daggone script. It's Valentine's Day. Sweetest day is about. There you go. Oh my goodness. Woo. Yes. Wait, it's a lot of stuff in here. Hold on. She said, head in the clouds, poor patients getting EOBs with denials, crazy cycle. Yes. I think I said this one already. They will have more money if they get those claims coded right. Absolutely. So yeah, this has been wonderful today. Just, giving a lot of perspective, thinking about, being proactive, not necessarily reactive, and what's coming. Predictive AI, hell, predictive your life, predictive your profession, predictive whatever. You need to figure out, how you need to pivot. What should you be pivoting? Of course you should. Should you be growing and continuing to learn? This is a profession where there's lifelong learning. Absolutely.
Very much.
Absolutely. Build your toolkit, people. Build it. Because you can't get comfortable right here because that's gone. That's gone. You got to have multiple skills out here to pay these bills.
Multiple.
So consider that. So thank you all again for joining the Saturday morning tea. Or if you are checking out the replay, thank you for that as well. Was the tea spilled today? Was it spilled today? Let us know in the comments. We would love to hear your thoughts. If this information was valuable, yes, ma'am. Oh, if this information was valuable for you, please let us know by sharing this message with others, where you can share the video and subscribe to the channel. Again, we know what we talk about, but other folks really, really do need to hear this message, because they may not even have the same perspective or think about the same perspective or issue. And sharing is caring. Sharing is caring. So be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And how can you keep up with that? By subscribing to the channel. So you can subscribe to the Professional Reimbursement Network channel. You can subscribe to the Coding Nurse channel. There's all kinds of information and tea spilled on a regular basis. So as you leave out, don't forget to hit the thumbs up and like button. We need engagement. We need the engagement to move around so other people's we can get in folks' algorithms, and y'all know how this thing works. So we can reach more and more people. And invite them to the table, invite them to the conversation, invite them to the tea party where they can give some of their perspectives. I would love to have a gatekeeper in here. And let's
too.
Not a gatekeeper. Let me go see if I can find somebody who would feel like they are a gatekeeper and want to defend their gate. Yes, and put your teacups in the chat. Put your teacups in the comments. Yes. So this has been a great session today. Thank you for spill tea with a pinky up, please. Exactly. Thank you for joining us. And remember, be safe, be kind, and don't wish for. Wait. Before I even get there, Mr. Jesse, did you have some parting words? I'm just going on and on.
I think I've said enough today.
You done made up for some of them days when you ain't had nothing to say. So I'm loving it. So remember, be safe, be kind, and don't wish for it. Work for it. Until next time. Remember, we won't be here next week, but I'll see you in 2 weeks.
All
Take
right.
care.
Bye,
Take care.
everybody.